super specialty hospital, Saket, New Delhi. His expertise includes procedures of TAVI, structural heart disease, coronary angioplasties, peripheral renal and carotid angioplasty, electrophysiology study and RF ablation with 3D mapping. He's also done his TAVI and structural heart fellowship in USA, Europe and Denmark. He is a fellow of Society of Cardiovascular Angiography and Interventions, American College of Cardiology, European Society of Cardiology, and fellow of the Southeast Asian Interventional Cardiology Society. He is also being awarded the Chikitsa Ratna Award (DMA), Vidya Ratna Award Kanpur University 2010, and the International Award of Excellences in Cardiology at Mysore. I welcome Dr. Vivek Kumar as the moderator. It gives me immense pleasure again to introduce our panelist, Dr. Rajiv Parak, who is the Chairman, Division of Peripheral Vascular and Endovascular Sciences, Vedanta Medicity, Gurgaon.
So actually I am participating in a webinar which is on basically on angioplasty and the treatment protocol for chronic stable angina, treatment protocol for angioplasty, especially in what medicines to be given. This is being organized by company Zydus Kedla, and I am one of the panelists.
And Delhi Medical Association and its special interests include endovascular management of peripheral vascular disease, peripheral endovascular.
So actually the topic of discussion today is that we have to see a lot of medicine which have come newly, especially those patients who have undergone angioplasty एक साल पहले. एक साल के बाद हम लोग को एंजियोप्लास्टी के बाद खून पतला करने की दवाई दी जाती है. उसमें कुछ चेंज आए हैं जो कि एंटीकोगुलेंट है रिवोरक्सबीन, उसको एक साल बाद शुरू कर सकते हैं. और ऐसी कंडीशन में यही डिस्कशन है क्या हम जो क्लोपिटोग्रेल
scientific course chairman of the Indo-European course on revascularization and is the founder director of the Indo-European Intervention Council. His name reflects as the first in many multi-vessel angioplasty and stent, and he is also involved in the initial work of TAVI. He is the course chairman of the International Cardiology Teaching Course, the Indo-European course on revascularization. He has various prestigious fellowships and awards during his 30 years of his career. He is the recipient of the Glory of India Award, July 2007 at London, UK, Best Citizen of India Award, Delhi Ratan Award, and the leading health professional award, Cambridge, UK, in July 2007. We welcome Dr. Vivek Gupta. Next, it's my privilege to introduce Dr. Vivek Mathur, who is a consultant interventional cardiology, Mithal Hospital and Research Hospital, Ajmer, Rajasthan. He is a fellow of Society for Cardiovascular Angiography and Intervention, fellow of European Society of Cardiology. He has the European certificate of being fully certified in Heart Failure Association for life. He is a member of European Society of Cardiology and member of European Association of Percutaneous Intervention, junior consultant interventional cardiology at the Fortis Escorts Heart Institute, Okhla, New Delhi. May I welcome again all the delegates and request Dr. Vivek Kumar to kindly take the academic proceedings forward. Thank you.
So, good evening to all of you. I think this is a very testing time for the humanity. This pandemic, COVID has taken a toll, and I think still India is not as devastated as in most of the other countries, especially the US, Italy, and the UK, I would say. But nonetheless, I must thank the to guide us for bringing us together on this Revolution Summit, where we will be discussing on the newer antiplatelet roles, and then there is a paradigm shift in management of chronic coronary disease, which we have been saying till now as chronic stable angina. And we also have, I must say that the panel discussion has been heavily loaded in favor of individuals named Vivek. So we have three of us here. So it's a reacting majority. So the first time we are so many of us in the same panel. Hello to our friends Dr. Vivek Gupta and Dr. Vivek Mathur and Dr. Parak. So Dr. Parak will be in between at the moment, because there is a very revolutionary data about regoraxaban, low dose of what we call vascular, peripheral vascular disease as well. So I will request you to go through the vascular portion of the slides for the benefit of the audience. So hello, Dr. Parak. I think let's share the screen and get going. So, can you see the slides? Can you? Yes, I think if the slides are all of you can see, then we as the title of this presentation says that there is a paradigm shift in the management of acute coronary syndrome and the chronic coronary syndrome. So, if you look at the acute coronary syndrome and chronic coronary syndrome, the preamble of the whole presentation is that we know for quite some time that acute coronary syndrome is an emergency situation and it should be treated through immediate intervention. And there are lots and lots of data which have suggested that we need to do immediate intervention to acute coronary syndrome, or at least we should be very, very aggressive to antiplatelet and anticoagulant agents to get over the crisis of acute coronary syndrome. There are a lot of emphasis on non-interventional acute coronary syndrome. Simply because of the issues, we don't really know which patients will have COVID positive or which will not. If you look at the current data about acute coronary syndrome, apart from the dual antiplatelet, there is emerging data that beyond up to 3 months we can give dual antiplatelet, and if we have put our patients on the stronger because it's not very new, but this data is new that after 3 months they can be on single antiplatelet, that is, because a lot of patients with prior history of ischemic event at a higher risk of technical myocardial infarction in future. And this is a fact which I want to nail it quite heavily, because this is something which is not really appreciated, and people feel that one event is over and probably we are good for quite good number of years. So that's not true. These are people who would have higher risk of recurrence. And then various type of chronic manifestations would be there. And this is something called collectively as chronic coronary syndrome, and in the subsequent slides we will be discussing that it is not chronic stable angina. Chronic coronary syndrome is something which is continuum of acute coronary syndrome and which keeps on bothering patients if they are not on appropriate medication. And recently the management of chronic coronary syndrome, rivaroxaban, a vascular dose 2.5 mg twice a day, and with low dose of aspirin has shown very promising results in terms of cardiovascular mortality reduction. So that's very impressive data. If you look at the coronary artery disease, which is now classified into acute coronary syndrome and chronic coronary syndrome, and acute, all of us know scale HMI, non-scale HMI, various grades of unstable angina. When we look at the chronic coronary syndrome, that includes what we used to call chronic stable angina, but there is also new heart failure and suspected coronary artery disease. Patients who have the stabilized symptom for less than a year post ACS or post PCI, what we call post revascularization of coronary syndrome. Stabilized symptoms for more than a year post initial diagnosis. Patients with angina and suspected microvascular disease and asymptomatic coronary artery disease, which is detected as screening. So if you look at the natural history of chronic coronary syndrome, it's a dynamic process, as I said. If you look at the cardiac risk, death and myocardial infarction that keeps on growing, and the patients where they had higher risk are there because they had multiple episodes, because they had insufficiently controlled risk factor, suboptimal lifestyle modification, and medical therapy were also not appropriate. Whereas some of them would have revascularization and post-revascularization if they are on appropriate treatment, appropriate lifestyle modification, they would not have many subsequent events. Whereas in the middle, the blue chart, it shows that it is in the middle part of both each stream. So I think we need to be very, very correct. Our executed, obviously, as per the guidelines, we need to get the ECG done, vitals done, all these within 10 minutes, and then you have to give the IV access, oxygen, and pain relief agent which was done in this patient. So this is an ECG presentation. You can see clearly that it has a inferior ischemia. Plus, you can see there is a reciprocal changes in the artery, including the right sided. Even if escalated, so it means that there would also be some issues. And his cardiac markers were elevated, I was elevated, and he was high. An echocardiogram shows that he was severely hypertensive. So all these things suggest that the patient had inferior valve acute ST elevation, mitral infarction, and the patient, the best possible treatment used, it was a non-COVID era patient, immediately was rushed into cath lab for the angiogram. You could see that there were here and there few lesions left circumflex and LAD, but it was an acute occlusion of the mid-right coronary artery, which was opened up with one stent, and it immediately was achieved and the patient did well. So this is, we should not stop managing these patients. Then we need to educate them that it's a lifelong disease which needs a further evaluation. If you look at the PCI in cath lab, patient was treated with high dose of atorvastatin and aspirin. And obviously, as we know, we need to load these patients with second, protein P2Y12 inhibitor. So which one we should be giving? We'll answer this question. We have the options of preparatory blood and prasugrel. The patient underwent percutaneous angioplasty with stent into the infarcted artery. Always do. And the echocardiography showed after the angioplasty that is a mild hypokinesia of the inferior wall, which was very severe, and the function of right ventricle and left ventricle are almost normal. So that's the beauty of the primary PCI. So the question is that in PCI and cath lab, which is the preferred, which is the most preferred criteria to prescribe during the P2Y12 inhibitor along with aspirin, because aspirin is our old time-tested medicine, has to be with most of the drugs. So preferred criteria for P2Y12 selection, inhibitor selection in cath lab is that it should be quick in action. As we know that there are few of them, especially preferably for a very delayed, the onset of action would be more than 8 hours, so that is the reason why this confounder needs to be more. It has to be maximum IPA treatment in short duration, has to have sustainable effect in next dosing, faster onset of action should be active molecule, and no generic variation should be there. And the bleeding event should also be really safe. It's not yet clear of IV. So when you compare protozone, prasugrel, and ticagrelor, you can see that the ticagrelor is this. It's all the correct boxes. It is not pro-drug, have got mean ADPA activity 30 minutes, and mean IPA 2 hours is almost 90%. So that makes it a more choice. So if you have a prasugrel, it is a very long acting, and so unless we are committed for PCI, so before angiogram, you can't give prasugrel. You have to know the coronary anatomy, and then the prasugrel can be given. So that way, ticagrelor ticks the right boxes. The second question based on this case is that the post-PCI at discharge, which oral antiplatelet should be continued along with the aspirin as correct. Obviously, 99% of the time, the tablets which are loaded, we try and give this country the same unless there is an issue. So let's look at the plateau data that shows that ticagrelor reduces the cardiovascular with early benefit from 30 days to 12 months of the therapy compared to the placebo. We can clearly see that the graph started separating quite early, and then up to 12 months, you can see that the ticagrelor did significantly better. The cumulative adverse event rates were significantly lower in ticagrelor compared to the placebo. And if you look at the data from the same primary outcome of MACE plus revascularization was reduced by whopping 53% compared to the placebo. So meaning thereby that ticagrelor was much superior in all the cumulative incidences compared to placebo in this situation of the clinical trial. And we know that there are limitations of prasugrel. The overall, increase in any major bleeding is a big adverse event of prasugrel, which has led it to go into disrepute. And it cannot be given in elderly patients more than 75 years, and with the aging population, these populations is increasing in our society. Patients who are underweight, less than 60 kg, so in Indian subset, there are a lot of patients, poor and and if the patient had prior history of a stroke or PIU, and the subgroup analysis where it was found to be really good was acceleration MI. So that's why I said that we need to be committed for acceleration MI. Then primary, generally we can give prasugrel. And the patients who are diabetic and have stent thrombosis there for the better dose. But the black box warning for increased risk with severe bleeding, the dose adjustment required in patients who are less than 60 kg. Patients who have had, want to get a stability done there again. And that is why in Japan they have got 2.5 milligram of prasugrel, 5 milligram of prasugrel available, because they can, their population data in Japanese, which are smaller trained people, have shown that 2.5 milligram maintenance is good against 10 milligram maintenance. So if you look at the Ticagrelor, it's like one-stop solution in all types of coronary artery disease patients. So you can give it in unstable angina, unstable, you can give it in musculation MI, and even in chronic coronary artery disease, whereas the data also shows that beyond 1 year also up to 36 months you can give it safely. And regardless of treatment, whether the patient is going for, the beauty of this molecule is that whether it is medical management, PCI or CABG, all three arms should be well with Ticagrelor compared to the clopidogrel. So that is why it is something very good. And then with a very, very cautious approach. The hemolysis is something where we need to be watchful if we are giving this molecule. This So the medication prescribed in this gentleman was aspirin, Ticagrelor, atorvastatin, full dose 80 mg, metoprolol 50 mg, telmisartan 20 mg, metformin for diabetes, and advise the patient for proper lifestyle modification, which is very, very important, and importance of adherence to these medications, and was asked to come for the follow-up at every 30 days for next 3 months. So the question next one is that can patients be shifted from DAPT to P2Y12 inhibitor based on monotherapy Ticagrelor only after 3 months of PCI? So we have been thinking a lot about this, and there are data which suggest. So if you look at this study that shows that Ticagrelor with or without aspirin in high-risk patients after PCI, so there, even if the patient is complex, the lesion is complex, then also if you see Ticagrelor plus aspirin or Ticagrelor alone with the placebo, the standard of care almost 18 months follow-up was done, and the primary endpoint was mainly looked at hypothesis of part 2, 3 or 5 bleeding between 0 to 12 months after randomization, and key secondary endpoints were non-inferiority hypothesis, that is non-fatal MI, stroke or all cause death between 0 to 12 months after the randomization. And this data was representative of Indian patients also, nearly 700 patients were from India, including our center. So if you see all these data that clearly show that there was 44% less bleeding with Ticagrelor monotherapy, meaning thereby that if you give monotherapy with Ticagrelor after 3 months, you save 44% reduction of bleeding, and then the bar 2 and 3 bleeding was there also significantly lower, and no difference of efficacy, meaning thereby there was no trade-off that if you decrease the risk of bleeding by the single antiplatelet in the form of Ticagrelor, you will invite more stent thrombosis for acute condition. So that's not true. You can see there as overlapping graphs. So among high-risk patients who underwent PCI and completed 3 months of DAPT, Ticagrelor monotherapy was associated with a lower incidence of clinically relevant bleeding than the Ticagrelor plus aspirin, with no higher risk of death, MI or stroke. And if you look at the guideline also, ACC 2016 guidelines on DAPT post PCI, we know that 1 year is the mandatory we need to give, of dual antiplatelet. So if we see that the medication continues for 12 months post PCI, so this is the medicine, the same one which he was prescribed at discharge, and the patient continues to be taking these medicines. So if you look at the question next, that after 12 months of PCI, this patient will be considered as what? Would he be considered as chronic stable angina, or will be considered something else? There is a new nomenclature which is called chronic coronary artery disease, and this is something which I wanted to emphasize today, that this is a disease entity. It all should be adhering this terminology, because you could not say that after angioplasty or after acute myocardial infarction the disease will vanish. It's not true. It gets converted into chronic coronary artery disease and chronic coronary syndrome. And if you look at the resistance, patients with prior history of MI remain at a high risk of ischemic events. So if you look at the stable atherosclerotic disease, prior ischemic event more than 1 year, prior ischemic event less than 1 year, and there were 4 years outcome data in nearly 65,000 patients with more than 45 years of age. And this looked at cardiovascular death, MI, and stroke. And you can see the risk of cardiovascular death, MI, and stroke that was, annually quite significantly present there. So the patients who had previous event, they are at a higher risk. So MI, stroke, or cardiovascular death in 1 year post-MI survival population, 1 in 5 patients event-free at 1 year post-MI had an MI, stroke, or cardiovascular event in 3 years. So of these 20% of patients who experienced an event over 3 years, 40% of them had myocardial infarction, 18% had a stroke, and 40% had a cardiovascular death, meaning thereby that cumulative 3 years incidence of MI and stroke or cardiovascular death was there in almost 1/5 of the patient. And out of that, 40% would have MI and 40% would have death. So you can see how devastating the cardiovascular event he was in patients who have one episode of acute coronary syndrome or PCI done in the past. The myth of stable coronary artery disease has to be broken, and the risk of recurrence, MACE, and all-cause mortality significantly increases in patients with prior history of ischemic event. So it mean that stable coronary artery disease is myth? The answer is yes. Then the reality is chronic coronary syndrome, and that is what the nomenclature has been given by the European Society of Cardiology in 2019 recommendations. So the fifth question is, which antithrombotic therapy regime should be continued in chronic coronary artery disease patients? So if you look at whether we need to give, because if you look at the guideline wise, after 1 year, after acute coronary syndrome, or after stenting, we should do single antiplatelet from dual antiplatelet. Pegasus data and other long DAPT data did show that up to 24 months to 36 months, dual antiplatelet due to the Pegasus 60 mg twice a day data along with aspirin did show in Pegasus that ischemic events are slightly lower, especially the stent thrombosis and the other vessel events. Or should we think something else, that is dual pathway inhibition, because one single antiplatelet aspirin low dose will be there, and you combine the direct thrombin inhibitor and be done with that. But we needed an evidence to support that. The single antiplatelet with aspirin has a residual risk, we know, and that is why we are looking for what next can be done. You can see that the aspirin in primary and secondary prevention of vascular disease, collaborative meta-analysis of individual participants with touch to retain. Here you can see that the residual risk is very high, almost 20% for MI, almost 20% for MACE. Mortality is also almost 9%, and stroke is also around 20%. So aspirin alone is modestly effective. 19% relative risk reduction at preventing the secondary events with a residual risk of recurrent and inflammatory thrombotic event between 5 to 9% over subsequent 1 to 2 years. So we had P2Y12 inhibitor based DAPT does not reduce the cardiovascular death and increase the major bleeding risk as well. And this is the data which I was talking about, the Pegasus data. The Pegasus did not reduce the cardiovascular death and increased bleeding risk in patients with prior natal infarction, though the ischemic events were slightly lower. The peer intake assess 60 milligram was used, and in charisma DAPG also the event rate for 5 DAPG was significantly higher. So current unmet needs in single antiplatelet therapy and dual antiplatelet therapy, the MACE reduction is significant, but no significant benefit in cardiovascular death protection, no significant benefit in all-cause mortality reduction, and again, no significant benefit in major adverse limb event rate, what we call wave reduction, which Dr. Bharat will be looking at. And so we need to have an optimization of vascular protection. The dual pathway inhibition targets both platelet activation and persistent hormone generation in chronic coronary artery disease. So this is what we meant by dual anti-target. So we can act on the platelet activation as well, and also we can generation also mediated. So dual pathway can decrease the risk of. So this is how the coagulation pathway factor is there, and this is the dual pathway inhibition. Platelet pathway, synergistic effect of both the anticoagulation and antiplatelet drug provides a complete vascular protection, and that has to be understood really well. So this is the place where the rivaroxaban, Tacrotene, and the guns will be working. So dual pathway inhibition therapy optimizes the vascular protection in chronic coronary artery disease patients. And so the question is that why vascular dose of rivaroxaban 2.5 milligrams twice a day with aspirin would be the most preferred option for chronic coronary artery disease management. So the data had come from COMPASS trial, the cardiovascular outcomes for people using anticoagulation strategy, and it's a very large trial, nearly 28,000 patients were included. And you can see that it had 3 arms, rivaroxaban 5 milligrams twice a day, aspirin 100 milligrams, and rivaroxaban 2.5 milligrams twice a day, and the aspirin 100 milligrams. And the thrombotic investigation was stopped 1 year ahead of expectations in February 2017 with the overwhelming efficacy in the rivaroxaban 2.5 milligrams twice a day plus aspirin. So, meaning thereby the results were so robust in favor of low dose or vascular dose of rivaroxaban 2.5 milligrams plus aspirin 100 milligrams in significantly reducing the cardiovascular mortality. So, the COMPASS inclusion criteria for the coronary patients was 85 MI within last 20 years, multivessel coronary artery disease, multivessel PCI, multivessel CABG, and patients with CAD must meet at least one of the criteria: age more than 65, and then age less than 65, plus atherosclerosis in more than 2 vascular deaths, and 2 additional risk factors like patients who are diabetic, chronic kidney disease, or smoker, and heart failure patients. For peripheral vascular disease patients, the criteria was that the previous revascularization, previous limb or foot amputation, or arterial revascularization, and the history of intermittent claudication. Ankle arm BP ratio is less than 0.9, significant peripheral artery disease documented by angiography or Dr. ultrasound, and previous carotid revascularization or asymptomatic carotid artery disease, where the significant luminal narrowing was equal to more than 50% as diagnosed by the ultrasound or angiography, and CAD plus the ABI was less than 0.9 when the inclusion criteria. The vascular dose of rivaroxaban and aspirin, that is 2.5 milligrams twice a day plus aspirin 100 milligrams, that almost MACE reduction was significantly reduced by 34%. You can see that the patients who were on aspirin alone compared to the aspirin plus rivaroxaban, the CV stroke and MI rates were significantly lower, numerically 379 versus 496. So there was, and it was statistically significant. So, and stroke was also quite significant. So we demonstrated 42% reduction in stroke, 23% reduction in cardiovascular death, and 18% reduction in all-cause mortality. So that was really quite global. And then the other trade-off of increased bleeding was there or not. Look at, though major bleeding was high, but not different seen in fatal and intracranial bleeds. So the two things which we call bleeding, fatal bleeding, which kills the patient, or serious intracranial bleeding, which is the most serious form of bleeding, was not statistically significant, meaning thereby that the trade-off of increasing bleeding complications causing patients mortality was not there at all. So it was fairly safe that decreasing the ischemic event without causing significant increase in bleeding risk. The contrast trial subgroup analysis, if you look at the male incidence was also significantly lower. Almost in peripheral, there was even better, almost 46% relative risk reduction of peripheral ischemia, and the MACE rate was also 28% relative risk reduction that you could see from here. So that was really good. So 70% reduction in rate of amputation by vascular dose of levodopa with aspirin. So in peripheral artery disease patients also, the amputations were avoided in 7 out of 10 patients who otherwise might have lost. So I think from here, I will request Dr. Parekh to take over and Dr. Parekh.
Hello. Yeah.
Hello.
Am I audible?
Yeah, we can hear you.
Yeah. Okay. Thank you.
Continue this slide. So you want to share?
No. I'd like to start off with this. Actually, I know you've been through it, but I think this I can start this off as a basis for my talk. So
yeah.
Yeah, this one. That's right. Yeah. So that's right. Thank you. So thank you, Dr. Vivek. I think this is a great introduction, and I think the most important thing that we all have to realize is, as we know, is that atherosclerosis is a progressive disease, whether it is involving one system, two systems, or multi-system. Whatever be the areas, this is a progressive disease. There is no such thing as one event has cured the patient in any which way. So this is an ongoing syndrome, and it obviously then demands an ongoing treatment. So with a view to that, just putting these patients on single antiplatelet or even dual antiplatelet therapy for some time does not actually prevent significantly the MACE or the adverse limb events, because these are something which have been carrying on for a period of time. So Compass trial actually opened up this completely new paradigm, which actually has revolutionized treatment, medical management of the patients with peripheral artery. Now, there have been previous studies in the past, the Pegasus, the Charisma, and other trials, but they were never sufficiently powered to be able to give us the confidence that peripheral arterial disease indeed was benefiting with dual antiplatelet therapy. Whereas Compass, with its almost 38,000 patients, as Dr. Vivek has said, and coming up with the data over 23 months, this was, as he very rightly mentioned, this trial had to be prematurely withdrawn because of the overwhelming results and in favor of the efficacy and the safety of this dual therapy, and the significant reduction in the cardiac events as well as the limb event, going up to almost 46% risk reduction, and with a 70% reduction in the rate of amputation by this vascular dose, has actually completely changed our thinking and our line of further management. Can I have the next slide, please? Yeah. Okay. So close on the heels of the Compass comes the results of this new study, which is called the Voyager, which is primarily on peripheral arterial disease in patients who have undergone within the last 10 days or undergoing peripheral revascularization procedures. So this is again something like a game changer, because this is another subset of patients who are probably more at risk of an immediate thrombotic episode, as well as long-term benefits, which is something that we are trying to hope to achieve in these patients. So the Voyager PAD, the study design was the efficacy and safety of rivaroxaban, the vascular dose, that's 2.5 mg, for the reduction of thrombotic vascular events in subjects undergoing the revascularization. So this was the 1:1 randomization with 2.5 twice daily with aspirin compared to aspirin alone. And in this was a subset in which they were also using clopidogrel in that subset, which means that the patient was actually getting trithrombotic therapy, that means rivaroxaban plus clopidogrel plus aspirin, and there was obviously a much higher risk of bleeding, but that is another subset that we'll be talking about. But coming back to the Voyager and the rivaroxaban twice daily plus aspirin compared to aspirin alone, you can see this curve, and you can see very early on, right in the beginning, within 3 months, you can see that the curve starts to separate and giving us a fairly significant primary endpoint at about 34, 36 months, and that is a relative risk reduction at 3 years of roughly the absolute reduction rate of roughly 2.6%, which is considered very significant because this is just the addition of this without any major adverse bleeding. This result can be achieved. Next, please. Can I have the next slide, please? Yeah. Okay. So, the three the studies that I mentioned, Prisma, Pegasus, and the Compass now, essentially, it's a very busy slide, but I can just draw your attention to three things. The adverse cardiac events, roughly 4.1%, reduction in the Compass trial as compared to 7.7 as seen and 6.8 in Prisma. So there's definitely a reduction in the adverse cardiac events here in the Compass trial as compared to the Pegasus, which was, as you know, ticagrelor plus aspirin, as well as Prisma was clopidogrel plus aspirin versus aspirin alone. So here the relative risk reduction as far as the cardiovascular death is concerned is up to the tune of 22% in Compass. This wasn't actually studied in the Pegasus or the Prisma as respects to the peripheral arterial disease. In terms of all-cause mortality, you can say it's almost like an 18% reduction in the Compass. Again, as I said, the reason why it's not studied or not significant is that there is an 18% reduction in the all-cause mortality as seen in the Compass as compared to Prisma and the Pegasus trial. There is a relative risk of bleeding events, and here there is a somewhat higher risk of hazard ratio is higher in the Compass trial is 1.7 as compared to Prisma. But this is something which I'd like to talk about here at this moment, that in the Compass study, they were very strict monitoring of all bleeding. So all bleeding, whether small, medium or major, were all reported. In fact, to the point of being over-reported, all bleeding. Whereas in Prisma and in Pegasus, the reporting was not to the tune, meaning all the bleeding events were not reported. So hence there is a slight increase as seen on the hazard ratio in the Compass as compared to the Prisma. But Prisma, as I said, reported only the major events. The minors were not were recorded as compared to the Compass. So there is definitely equivalence as compared to, as regards to the bleeding events in all these three trials. Next. Now coming to the real world situation. Yeah. Coming to the recommendations that we have been given by the European Society of Cardiology, the 2019 recommendation for the use of rivaroxaban 2.5 BD in patients with coronary and peripheral arterial disease. So there is a 2A recommendation in patients with, that is for the rivaroxaban 2.5 plus aspirin in all patients with PAD with or without diabetes when there is a high risk of ischemic events. So whenever there is a high risk of ischemic events, there is a 2A recommendation, even in patients with a high risk of ischemic event but with a moderate risk of ischemic events. Here as well, it is a 2B recommendation. So this therapy, which is the vascular protection afforded by rivaroxaban 2.5 BD, comes at a fairly high level of recommendation as far as the 2019 guidelines concerned. The 2019 Global Vascular Guidelines on Management of Chronic Limb-Threatening Ischemia it suggests that that we should consider low-dose aspirin and rivaroxaban to reduce adverse cardiovascular events and lower extremity, thrombotic events. And the level of evidence here, the class of evidence is 2. That means it is a consideration. That means that we should consider using this as compared to the class 1, which is, as you know, it's imperative. So it's not imperative as per the 2019 guidelines, because I think more studies and more numbers need to be added to this study. But it is, to my mind, not going to be par when we will have level 1, class 1 evidence to suggest that this is the way forward to prevent further events. So, next please. So I'm going to leave this back again with Dr. Viveka to talk about the events prevention for angina and dyspnea and coronary artery. Thank you.
Yeah, so I think that was very brilliant exposition of where the rivaroxaban in current day stands in vascular doses. And we also clearly said that this is something in line of the pattern of coronary artery disease management, and there also it did really show in peripheral vascular disease. Also, it gives immense protection, and the limb amputation rates are significantly lower. So, coming back to the rivaroxaban uses and the current recommendations that if you look at the ESC guideline, patients with angina and or dyspnea with coronary artery disease, even the recommendations are that antithrombotic therapy in patients with chronic coronary syndrome and in sinus rhythm. Adding a second, so it is very important that sinus rhythm is not just for the sake of keeping this all time. As you would know that if the patient is not in sinus rhythm, then you have to give the what we call atrial fibrillation stroke prevention dose, which is 15 to 20 milligram of rivaroxaban once a day, and there the risk of coronary artery disease has been shown to be decreased. But if the patient is in sinus rhythm, you don't really need to give vascular dose. The full dose for prevention of stroke has to be there. So addition of a second antithrombotic drug to aspirin for long-term secondary prevention should be considered in patients with high risk of ischemic event and without high bleeding risk. But what happens to those patients who are in atrial fibrillation? So the guideline is that those who are in atrial fibrillation, you don't have to add aspirin if the patient is more than 1 year of stenting, or patient has got if there is a patient is atrial fibrillation, you give the full AF or SWAP prevention dose of rivaroxaban, which is 15 to 20 milligrams. So addition of a second antithrombotic drug to aspirin for long-term secondary prevention may be considered in patients with at least moderately increased risk of ischemic event without high risk. And then the guideline is that it is a recommendation of class 2B. So to conclude, friends, I would say that in summary we can say post-acute coronary syndrome patients are on a high risk of development of recurrent ischemic event. That is why they are now called chronic coronary artery disease. Vascular dose of rivaroxaban with low dose of aspirin will prevent clot formation through dual pathway inhibition strategies, and which is a very smart way to look at this disease process. Rivaroxaban 2.5 mg twice a day is only NOAC, which is approved for both acute coronary syndrome and chronic coronary artery disease. There is no other NOAC which has got this recommendation for this indication. COMPASS trial has shown overwhelming efficacy in chronic coronary artery disease and peripheral artery disease patients, so that it was terminated almost 1 year before expected date of completion. The data was so strongly in favor of the vector. And while the previous study had shown significant benefit from rivaroxaban 2.5 mg plus aspirin in symptomatic peripheral artery disease patients undergoing peripheral revascularization, truly this is the combination which has created a revolution in the management of chronic coronary artery disease patients and the chronic peripheral artery disease as well. So when we revise the prescription after 12 months of the index patients, we pull out the ticagrelor and replace ticagrelor or the second antiplatelet with an antithrombotic agent, which is rivaroxaban 2.5 mg of vascular rivaroxaban, and rest of the things like antidiabetic, antihypertensive doses will remain the same. So thank you very much for your kind attention, and we will be taking questions if there are any. And first of all, before answering the audience question, I would like Sabir to get some comments from our panelists, Dr. Vivek Gupta and Dr. Vivek Mathur, and then we'll take the question from the audience.
Hello. Thank you, Viveka. Can you hear me?
Yes, we can.
So thank you, Viveka, for a very nice comprehensive review of rivaroxaban, which has now been confirmed. And I just wanted to add that this campus trial was actually published in American College of Cardiology in January 2018. And FDA was very quick to approve this medicine, rivaroxaban, beyond 1 year in chronic syndrome in October 2018, and it is FDA approved also. And I think now the patent has been off, and therefore it can be used by many other companies. So there is no doubt that this salt is very useful, although there are some hiccups regarding the increased gastrointestinal bleeding, and I think there is some trial with the pantoprazole also, which I don't know the detailed data. So in this group of campus trial, I think pantoprazole was not added. I'm not sure. Viveka, can you tell me? Because if we add pantoprazole, because the hiccup is that increased gastrointestinal bleeding, which is a non-fatal bleeding, but still it is there. It was increased in the group which was having aspirin plus rivaroxaban. Although the net clinical benefit was in favor, with the hazard ratio, as you told, is about 0.8 and 95% risk reduction, which is quite significant when you add up the mortality, the fatal MIs, and also the bleeding. So pantoprazole was added in this campus trial or not? I'm not aware. Viveka, can you highlight this?
So it was not added because the GI bleed was slightly more in AF suppression dose, which is the full dose, 20 milligrams. So this was the vascular dose, 2.5 milligrams. So that's why it was.
I think there was another trial which I was reading, that there may be another trial where they would add pantoprazole to see whether the gastrointestinal bleeding will be still high or not. So in our setup in India, we are all using pantoprazole always in such patients who are on ecosprin, and now we are adding rivaroxaban. Of course, I think that problem of that hiccup of increased gastrointestinal bleeding may not be there when you are using pantoprazole along with. So there is no doubt that this is a very important addition, and there is a major change that you stop ticagrelol after 1 year, you add rivaroxaban and with aspirin, and you will not have any major clinical event as much as what it was having along with. And ticagrelol alone with combination with aspirin will have more bleeding issues, and therefore it has to be stopped, and then you add it with the low dose or vascular dose of 2.5 milligram. My question was there, Vivek, just for discussion. Any patient who is having a peripheral, the deep vein thrombosis, and suppose he is on dabigatran, just for discussion, he's already taking dabigatran. Now we have no data for dabigatran as such for prevention of adverse events or reduction of adverse event beyond 1 year. So would you be inclined to change from dabigatran to rivaroxaban in such patient? You understanding my question? My question is that some patient you receive at 1 year post PCI, he or she has got a peripheral deep vein thrombosis, and somebody has already started dabigatran. So with the data coming from campus trial for only rivaroxaban, not for dabigatran or anything or Novak, so would you be changing to full dose of rivaroxaban? Because of course when you have DVT, you have to have full dose as a prevention for 3 months or 6 months. So or we can continue with dabigatran itself. What is your say, Viveka, or anybody else?
Yes, I think if you look at the protection for both, I'll invite Dr. Parek's comment as well after mine. So the thing is that if you look at the coronary protection with the dabigatran, coronary events, they are higher paradoxically, not lower. So I would say that if the patient has deep vein thrombosis, has coronary artery disease simultaneously, it makes sense that we should switch them to rivaroxaban. And when you are given, as I said, when you are giving it in a deep vein thrombosis dose, then you don't need to give aspirin. You can stand alone. Novak is good enough. If you look at the Augustus data post PCI, after 1 year you don't have to give any antiplatelet. Just the Novak is good enough. So that is same logic we continue with rivaroxaban also. The
That means the conclusion is that in a patient who has got deep vein thrombosis, he comes to us and somebody has already started dabigatran. That means we should be obliged or inclined to change it to full dose of rivaroxaban and stop ecosprin. This is what you say.
Yes.
But if the patient is already having coronary artery disease, I'm not talking of that.
No, coronary artery, that's what I said, that even if the patient has stent, if you are giving the patient
full dose
after 1 year, you don't, if the patient is taking any NOACs, so the data from Augustus is clearly that if you are giving the patients the apixaban 5 milligram twice a day, after 1 year you don't have to give antiplatelet. Real critical PCI, that there also after 1 year data is clear that you don't have to give antiplatelet, just the NOAC is good enough. I will also invite Dr. Parak's comment on this.
See, first of all, the COMPASS data is based on arterial thrombotic effects. It does not actually talk about deep vein thrombosis or the venous side of the clot coagulation. And obviously, as you know, the difference between the venous and the arterial side is the venous component requires full dose anticoagulation, which could have been dabigatran or rivaroxaban or whatever. But the fact is that dabigatran actually is not as protective for the coronary circulation as compared to rivaroxaban. So if a patient is, with an acute coronary syndrome or a chronic coronary syndrome for that matter, develops a deep vein thrombosis and somebody has put him on dabigatran, I think it probably worth his while to be switching on to full dose rivaroxaban rather than continue on dabigatran, because that would cover both the therapies.
So would it not mean that for DVT in elderly patients, about 50, 60, where the coronary events has not happened and we don't know the clear coronary artery disease, he has not gone into CT scan, CT coronary angio has not been done, you never know, there may be hidden coronary artery disease. So it will be a wise idea to in fact do rivaroxaban full dose rather than dabigatran. Considering that only one COMPASS trial has shown, we have only one data, as you say, that's more of a coronary and peripheral vascular protective, arterial side, while dabigatran and other NOAC has no as such. So I think my feeling is that rather than keeping them on dabigatran or any other NOAC, it is more wiser to put them, especially after 50, 55 years, where the CAD is not known. It may be hidden ischemia or it may be hidden something because you're not always testing. So it will be wiser to do a full dose of rivaroxaban rather than any other NOAC.
I think we should go by the inclusion criteria of COMPASS, and so it's not that it is a universal drug should be given to anybody who is beyond the age of 55, 60 years. We need to look at the inclusion criteria. So those who had prior MI, even 20 years back, if they had an MI, that was included. Patients who had a revascularization, CABG, stenting, or the patient had more than two risk factors for coronary artery disease, then only we should be including. So I think it's not a universal drug. It's not like an statement where everybody should be taking this. So my take is that we should go by the COMPASS trial data and those include the patient. And that is why the guidelines also, if you look at the guideline, it's 2A at best. It's not yet gone to 1A level. So that is one of the reasons is that we need more data. Though the trial was pretty big, but still we need a couple of more trials to bring it to level class 1 indication. Dr. Vivek Mathur, you would like to say something?
My comment is regarding the COMPASS trial and all. I would just like to know for how long can you prescribe this combination? As we have seen from the various registry point of view, the risk of events increases over a period of time, even up to 7 years and 10 years data suggests that as the time from the index event increases, the risk of events increases also with the duration. So if the strategy is employed to give the dual inhibition of anticoagulation as well as the antiplatelet pathway, so would you think that for how long, beyond 1 year after the index event, 2 years, 5 years, so is that the recommendation to follow for a long duration in these patients for secondary prevention?
So in medicine, there is nothing lifelong. If you look at the COMPASS data, this is 3 years follow-up data. So that's what I said, that after a couple of years, maybe we will have a 5-year data those same patients will be presented and their data will be collated, and we will see whether at 5, because there are a lot of these trials they continue to do follow-up. Like recently we had 10 years data of the STITCH trial. So similarly, I would say that the 5 years data of this trial will be collated and be presented. So as of now, if you look at the guideline wise and the COMPASS data wise, it is only for 3 years. Beyond that, I don't think the risk factors will go down. So as it increases, to my mind, probably it is a long-term medicine which will decrease, because one of the major thing which really strikes is 20% cardiovascular mortality risk goes down. So I would say that a very, very robust molecule as far as the chronic coronary artery disease event reduction is concerned. Look, if you look at the data from Pegasus, there also the MI rates were, or acute coronary syndrome rates were lower, and that too only for 6 months. But this is a molecule which has shown its superiority, especially in hard endpoints like mortality, up to 3 years. So I would say it's going to stay for longer. To my mind, I think we can bet that 5 years would be a good choice. Dr. Parak wants to say something.
Yeah. So I would completely agree with this. This is a long-term molecule because this is a progressive disease, as you know, atherosclerosis and multi-system involvement is known, and that is what is progressive. The data currently tells you to use it for 3 months, 3 years, because that is what has been studied. But if you see the curve, one of the slides which Dr. Vivek showed us, the curve actually keeps diverging. So that means the risk reduction increases with time. So the protection that you get with time is increasing the longer that you take this medicine and molecule for. That is number one. The other two things that I would like to bring to this, to this forum is that there is a 45 to 48% risk of death, cardiovascular death, in patients who have suffered an amputation. So any patient with peripheral arterial disease, a diabetic patient with peripheral arterial disease, if he undergoes a major amputation, 48% of these patients will be dead in 5 years. So this is the data that we are actually looking at, and this will give us whether this group of patients actually benefit in terms of longevity if you continue to use this drug beyond 5 years. And I think we'll have to obviously wait for those 5 years with this trial. And of course, if there are other trials which come in and add to this data, the level of evidence, as Dr. Vivek has said, would definitely go up. And probably one day I wouldn't be surprised, because to me, as far as my practice is completely changed, I am using rivaroxaban vascular dose in practically every patient with chronic peripheral arterial disease, chronic threatening ischemia, and also for all our patients undergoing vascular intervention. So this is something which, and we will keep them following up. We fortunately have a DNP program, and I've given one of my students this as a thesis. So this will be carried on in our institution from now onwards for the next 2 years. So hopefully we should have some personal data as well. But to my mind, I have no doubt that this is the molecule for future for peripheral arterial and of course coronary artery.
Yeah, so I think Sameer, would you throw those questions?
Do you have questions from audience?
Sorry?
Do you have questions from audience?
Yeah, there are a few questions. Actually, there are many questions, but in the interest of time, 2 of them are already answered. So there's this one question from Dr. Sanjay Bhatt. He says that there could be a chance of dealing with dual antiplatelet therapy. So in view of this Twilight study, after 3 months, would it be rational to shift to ticagrelor monotherapy? What would be the opinion of the panel from the clinical perspective?
Yeah, so Vivek, Martha, would you like to say?
See, the clinical judgment of bleeding has to be there, I think, after 3 months, and the index case, what kind of case that you have for example, diabetic patients, CKD patients, and all these patients have to be on dual antiplatelet therapy. But if the index case is such that we can go for the bleeding risk is not that much, so we can go for a dual the monotherapy with the ticagrelor. And I think we have to judge by the bleeding scores and the DAPTs, the risk of thrombosis, stent thrombosis. They have to be judged accordingly, then only you can decide about the beyond 3 months, I think.
I think data is quite relevant that you can stop ecosprin after 3 months. But as of now, we are not doing it as of now. So in our clinical practice, we are continuing both. But we can think of it and we can start discontinuing ecosprin and continue only ticagrelor for after 3 months, considering the data. How many patients were enrolled in TOLAC trial? Because I did not go completely. Viveka, how many patients were enrolled?
So almost 1,300 patients in each arm. So more than almost 3,000 patients.
Because there's always a hesitation in the mind of all physicians and cardiologists to stop ecosprin after 3 months in post-PCI.
No, so to be honest, if you look at in my practice, I have started doing that. And if you look at the complex trial also, they are also in complex patients who are diabetic, patients who have got CKD. They are also in longer stents also. You have having data which shows that you can safely stop, and single antiplatelet was pretty good if you are giving ticagrelor. In fact, there is another ongoing trial which is from day 1 without aspirin, the single antiplatelet ticagrelor without aspirin, what we call standalone ticagrelor trial in post-PCI is going on, and I think another 6 months we'll have data from that also. That clearly it's going to be data where aspirin will be done away with permanently, because as of now, historically aspirin has got so much of data that we feel that it is something which you can't do.
Maybe it will take a few months time for us to really change the.
But definitely, I think the patients who are high bleeding risk, there is no doubt about that we should bring it to single antiplatelet in the form of ticagrelor.
After 3 months.
After 3 months, I think I would.
High bleeding risk patients, elderly patients who have shown some bleeding somewhere, maybe some occult blood in the stool alone, may be an important reason to stop ecosprin after 3 months. And it is equally efficacious. It's not adding to efficacy. I mean, the both combination not adding to efficacy of antiplatelet overall regimen. And the MACE is same. It's not increasing the MACE or any other adverse events of mortality. I think it's a good idea to stop after 3 months.
Yeah, since we are discussing peripheral vascular disease as well, so interestingly, ticagrelor has not shown any superiority in peripheral vascular disease. So I don't think Dr. Parak would be using it in his practice.
No, hardly ever. Yeah. Hardly ever. I mean, we may continue it because if the patient has had a recent coronary intervention and is on ticagrelor, we obviously don't stop it. But we'll continue with that, and then on the advice of the cardiologist, they say that you can stop it after say maybe a month or so. Then after a month or maybe 90 days, 3 months, we would then switch over to rivaroxaban 2.5 PD along with the aspirin. But ticagrelor as a dual antiplatelet therapy, aspirin plus this, is barely ever used for peripheral arterial reconstructions or for peripheral arterial.
Dr. Parak, you said you will stop ticagrelor after 3 months of PCI. No, at least we have to continue for 1 year.
That's right. No. What I'm saying is that this on the advice of the cardiologist, the attending cardiologist, whoever has done it, in case they say that yes, you can stop it, because usually it is continued for a year. I mean, ticagrelor would be continued for at least a year before switching over to rivaroxaban.
Dr. Muchla, any other question, Samir?
Yeah, we'll just take a couple of questions. This Dr. Swati says that she is a very prolific clopidogrel user since 12 years, but recent data says that the genetic resistance in Asians would go to as good as 60%.
50%?
60%. So then what would be is there any guideline which would suggest management of this clopidogrel resistance?
Viveka, are you answering?
Yeah. So I think we know that the data, if you look at the clopidogrel resistance in Asians and Indians, there's a lot of data which has come up, and the resistance level could be anything from 15% to 60% on the maximum side. And that is not absolute resistance. There's a lot of them with dose-dependent resistance. So coming to Dr. Swati's question, I would say that the best way to come over this resistance issue is to change your molecule. When you have got a better molecule, why not use it? Unfortunately, in India, the cost is not a big issue. You see, it has come out on off patent, and now you are having a cheaper ticket loss. I think we should go for this molecule, which will solve the issue of resistance. So, genetic variable response is something which is very bad for coronary artery disease patients, because the patients may have stent thrombosis and succumb to stent thrombosis. So, it's better to use from day one the better molecule.
But do we have any data of ticagrelor resistance? I have not heard. Anybody in the panel?
No, sir. So I don't think ticagrelor resistance.
Or it has not been tested? Or it has not been tested?
No, it has been tested, but the way it functions, the resistance is not there.
One thing, I think the bedside platelet activities testing is also not available and also not recommended also.
Yeah.
And I think the genetic testing only, I think it is also not in the practice also. So I think if something like resistance is suspected at the initial time, the better molecule, the prasugrel or the ticagrelor are the major advances in this field, I think.
We'll take one last question from Dr. Yash Shah. He says that how do you perceive the concept of dual pathway inhibition versus dual antiplatelet therapy in chronic CAD patients?
This has already been answered actually through all the slides, because dual pathway is better. This is what it said already. Viveka, please add on to that.
Yeah, so I think that is what we were, if you have, I think probably missed this slide. So it's clearly shown that the data from Pegasus and all did show that the cardiovascular mortality remained high despite increasing the dual antiplatelet beyond 12 months up to 36 months. The event rates were, the ACS event rates were slightly lower, but the cardiovascular mortality remained high. So that is what we call residual risk was there. So then the concept of making dual pathway more applicable, and fortunately the results were so startling in COMPASS trial that the trial had to be stopped 1 year before the completion. So meaning thereby that this is best way to go about. Having said that, there was the conceptualization of vascular dose was very important, because if you look at the 5 milligram rivaroxaban, that was not really at impact, because the bleeding, the risk outweighed the benefits which accrued. So aspirin low dose and vascular dose of rivaroxaban does do wonders, and it protects, because you don't want a double-edged sword that at one end it protects you, but the other side it causes increased bleeding risk. So that's not there with this vascular dose. So I think this is the best way to go about. And if you look at the older trials of warfarin and all, warfarin, the old drug in late 80s, people who were on oral anticoagulation, they used to have very decreased risk of myocardial infarction, acute coronary syndrome, and all those things. So this has been conceptualized from the historical data, and that is why people were looking at this thing. One of the reasons why warfarin is out of favor is that it's a variable response, and then hassle of measuring PTINR every now and then. So I think probably that's the reason. We need to get more data from other molecules. I know that there is after the Augustus trial with clopidogrel and apixaban up to 1 year, and beyond that, Professor Lopez is looking at that data for 3 years data of single antiplatelet apixaban, and that probably next ACC will be presented. So that will also show the coronary protection. But if you look at all the data and meta-analysis, none of the NOACs have got a superior coronary protection profile than rivaroxaban. The rest of them are not. Even if you look at the dabigatran, where the coronary events are paradoxically higher. So I think it has to be right molecule, and rivaroxaban is vascular dose. As of now, the evidence suggests it's best of the lot.
I'll just take 2 minutes now. We have done a poll with all the delegates who have started the webinar. So I'll just take this poll results, and we can have a discussion if required. So the first question was, which specific characteristics of oral antiplatelet drugs do you prefer most for prescribing in ACS patients? Faster onset of action, offset of action, significant CV mortality benefit, lesser genetic variability, and without any dose adjustment and comorbidity. So if you see the results, they say 77% goes to the second choice, which is CV mortality. So if Dr. Viveka and team would like to comment on this.
किसको दे रहे हो आप?
Yeah, can you share the slide?
दे तो 7 दिन का और का तो शायद अभी बिलिंग से फोन आया था, कोई फ्री वार्ड का भी लेकर आया हुआ है। बिलिंग से बात करो, बिलिंग से बात वहाँ ऊपर बात कर लो, आराम से आराम से।
Yeah, Dr. Vivek Gupta, would you like to comment on that?
So definitely the choice of drug in the ACS patient is definitely the drug with maximum mortality benefit and lesser bleeding will be the preferred choice. But as I think when you are taking a patient for an acute coronary syndrome, initially we want to give a drug which is also faster acting, and in the long run you also want that the patient in this category should also have the mortality rate should be lesser with that. And I think as with the plateau trial and all those things, as far as the comparison, the ticagrelor has definitely proven to be more superior than the clopidogrel, and the latest one trial was also there, that in which the prasugrel was also found to be better molecule as compared to vis-a-vis the ticagrelor.
Yeah. Next question.
Yeah. So this question is, considering the Twilight and Twilight complex studies, positive data of ticagrelor monotherapy, how would you prefer to treat high-risk ACS patients after 3 months of ticagrelor antiplatelet therapy? Shift to ticagrelor 90 BD or continue 90 BD with Raspirin as DAP? 80% say the second choice. So the opinion of the panel?
Yes, I think that's really good track from the delegates, because Twilight trial, Twilight complex have also shown that the ticagrelor 90 mg twice a day as a single antiplatelet is quite good now.
Go to the third question. In which type of patients will have high risk of recurrence of ischemic events like MI or stroke happen in the future? Patients with risk factors only, like obesity, diabetes, hypertension, patients with stable atherosclerotic disease, patients with a prior history of MI less than 1 year or more than 1 year. So 79% said less than 1 year. Again, any opinion on the same?
Dr. Gupta, would you like to
Sorry, actually I was...
I think this is from the different registries that you have. The event rates are very common in the initial first year, or maybe the initial first month of the index event. The rates of the events increases after one month, and they continue to rise till 1 year. So the high risk of recurrence is again definitely higher. So initially first 1 year of therapy, that's why we give dual antiplatelet for the first 1 year.
Yeah, so I think this question is rightly answered, that those patients who have, how many risk factors are there? But if they have got one MI incident, they are at a multiple fold, almost 4-fold higher risk of recurrent event. So if somebody is carrying 3 risk factors, then also they are at a lower risk compared to those who have one myocardial infarction event. So event is very, very important for it.
The fourth question is, which of the below mentioned characteristics would you prefer most to select an antithrombotic additional drug to aspirin in PAD and CAD management? Drug with significant reduction of adverse events and adverse limb events, drug with significant reduction of CV mortality in CAD and PAD patients, drug with significant reduction of major amputations, and all of the above.
It's all of the above, you said.
Yeah. 91% has said all of the above. Right. The last question before we can have the closing remarks from the panel. Considering clinical evidences from latest studies like COMPASS and Voyager PAD, which additional antithrombotic agent along with aspirin would you prefer in chronic CAD and PAD management? Again, it's ticagrelor 60, rivaroxaban 2.5, clopidogrel 75 and prasugrel 10 milligram. 85% have said rivaroxaban 2.5.
That's already answered it.
I think to add on to that, I think the trials are also ongoing for the ACS initial 1 year management. So I think in some part of the Europe it has been the results of Atlas and Gemini trial are also have been discussed. So in that case, in that they have also found out good results with adding to the first year of therapy rivaroxaban with aspirin. So we are still to see some more.
Okay. So can we have the closing remarks from Dr. Vivek Gupta before I use a lot of time?
Yes, I think we had a very wonderful discussion. I must thank our co-panelists, Dr. Parak, I think he has left, Dr. Vivek Mathur and Dr. Vivek Gupta, your friends. So I think in this difficult time, we had a very wonderful session, something to share about this evening, and we learned a lot many new things, and more specifically, the things which could decrease the mortality in not only the chronic coronary syndrome but also the peripheral vascular disease, and amputation rate decreased by 70%. That was a quite startling finding of these two trials. I would say that at the end of the day, if we treat our patients with sensible molecule selection, initially with ticagrelor and aspirin in acute coronary syndrome, and in chronic coronary syndrome, aspirin plus rivaroxaban, which is the vascular dose, and in patients who have peripheral vascular disease, aspirin plus vascular dose of rivaroxaban 2.5 milligrams per day, twice a day. Then I think a lot of our patients' mortality, cardiovascular events, and the amputation can be brought down significantly. So I think at the end I will give the honor to Dr. Sanil Chala for giving the vote of thanks, and then we will start.
Just a last comment actually. With the July trial, I think when we're talking about stopping ecosprin after 3 months, I think those patients who are having any history of stroke somewhere down the line during that period, I think then you cannot stop ecosprin, because then you have to give ticagrelor plus ecosprin both. This is my suggestion, especially if they have some history of ischemic stroke during that period. Okay, Samir, you can go ahead with the vote of thanks. Yeah.
Thank you, Dr. Vivek. I think we had great deliberation on the changing concept of management of acute coronary syndrome and chronic coronary syndrome. My heartfelt thanks to Dr. Vivek Gupta, Dr. Rajiv Parak, who just left, and Dr. Vivek Mathur for giving valuable insights on these ever-changing concepts. Because as it relates to acute coronary syndrome, we need to keep ourselves abreast with whatever small change is happening globally. My heartfelt thanks to Dr. Vivek Kumar for excellent moderation and for percolating the messages in a very lucid language. I'm happy to announce that we had 498 delegates from across India who have witnessed today's webinar. My heartfelt thanks to all of you all, because I know these are very difficult times, and you, along with academic interests, are also supporting our Indian COVID patients. So hats off to you, and let us all stay indoors, stay healthy, and may God bless all of us. Thank you very much. Thank you.
Thank you.
Thank you. Bye.
No. So this was an interesting webinar on antiplatelets, anticoagulants in post-angioplasty patients. This was more medical rather than to public. I think it has been very useful watch for all of you, and this will go on live and now recorded. Thank you very much for watching this video regarding the new insights coming from various trials in relation to angioplasty, और खास करके जो खून पतला करने के पब्लिक लैंग्वेज में जो खून पतला करने की दवाइयाँ होती हैं उसको कितने दिन तक चलना है, बिकॉज कई बार ब्लीडिंग रिस्क भी उसको ज़्यादा होती है, तो ब्लीडिंग रिस्क को कम करना है, हार्ट अटैक को भी कम करना है, तो इसलिए इस पर एक वेबिनार था जिसमें कि आई वॉज डूइंग द पैनलिस्ट एंड वी डिस्कस्ड अबाउट कि 1 साल देना है, 3 महीने के बाद एस्पिरिन बंद कर देनी चाहिए, कुछ और नई दवाई शुरू करनी चाहिए साल भर के बाद. दैट वाज ऑल. थैंक यू वेरी मच वॉचिंग दिस वीडियो.